Okay. We showed you a toe, more toes to come, although we are time constrained. Coronally, the view of the sesamoids for bipartite sesamoid fracture. The collaterals, true for all coronals. Osteomyelitis, although by far my favorite, is the sagittal T1. Fractures, bunions. Axial, toe position, metatarsus valgus, varus, etc. Sesamoid, position and fracture. We'll see the shape and appearance of the crista, which is the housing for the metatarsal sesamoids. I'll show you what the crista looks like in a moment. The suspensory ligaments are viewed in this plane. Callus may sometimes present as a mass, short axis for masses, entrapment neuropathy, and I'm going to show you an example of Morton's neuroma as an entrapment neuropathy. Sagittal. This is the view, the main view for the plantar plate, claw-toe, hammer-toe deformities, osteosagittal T1, flexors, extensors, and other long tendons, including the extensor hallucis. So here is a view of the great toe. This is the crista. The sesamoids should fit neatly into these paracristal grooves. The sesamoid is surrounded by hyaline cartilage, and it's cartilage against cartilage. So loss of that cartilage produces excessive friction and will degenerate the plantar plate. We have an intersesamoid ligament, the flexor hallucis, and then a set of suspensory ligaments. They can either go to the phalanx or the metacarpal. There are two sets on each side. So they're called the suspensory metatarsal phalangeal ligaments or the suspensory phalangeal sesamoid ligaments. So two sets on each side. And you are seeing the tibial suspensory ligament medially, and this happens to be the metatarsal suspensory ligament. It's not so important you differentiate which suspensory it is, as long as you identify that they are there. They function in a way that's somewhat analogous to the accessory collateral ligament. The plate. The plate has width. Now, the first metatarsal phalangeal joint plate is pretty strong. But when there's excessive arthritis and remodeling, and you get 75, 80, 100% of the plate from side to side gone, then it requires repair. Anything less than 50%, as we'll see in a moment, does not require surgical repair, but rather rest. The plate is much better developed on the plantar than on the dorsal surface, where it is inordinately thin and inconsequential. Here's a look at the plate in the coronal projection. The plate is depicted in blue. Here are your suspensory ligaments, phalangeal and sesamoid, attached to each sesamoid. There's another structure attached to the sesamoid, isn't there? It's the flexor hallucis brevis, the oft-forgotten muscle. So it has tendinous attachments to both the medial and lateral sesamoids. So if you tear this, or you injure the plantar plate and tear this, what happens to the sesamoid? The muscle pulls it proximally, and now you're no longer walking on the sesamoid. The sesamoid comes back towards the arch of the foot. Okay, this slide is showing you an example of a plate tear. So you're going to be assessing the plate tears from distal to proximal, and also the status of the plate from side to side. All right, let's take a look at our case. 63-year-old, concern for MPJ plantar plate tear, numbness of the second toe. Let's be consistent and start out with a sagittal projection. It's the T1 weighted image in the middle, PD spur on the left, adage, gradient echo, 2 millimeters on the left. This one is 3D. So perhaps the best way to look at the planar plate is with a smaller field of view than this, microscopy coil, 1 millimeter cuts, additive gradient echo, merge, MEDIC, or MFFE. This is by far my favorite sequence. My second favorite would be the PD spur. So the field of view could have been smaller, but it's still diagnostic. Let's take a look. Now, it's not uncommon to see areas of attritional tear, what I would call wear and tear variability in the thickness of the plate. So I'm not disturbed by this. I'm not disturbed by this because my plate is straight. My plate is consistent in its course. It's not wavy. And I can follow it from the medial side to the lateral side. So I can follow it all the way across. What about my articulation? It's a little bit of remodeling, but fairly preserved first MTP articulation. Here's our sesamoid. Which sesamoid is it? We'll cross-reference. It is the tibial sesamoid. What inserts on it? The flexor hallucis brevis. And you're seeing one of the suspensory ligaments, the metatarsal sesamoid suspensory ligament. It's the other sesamoid. There's the other FH brevis, the lateral one. Let's go to the third digit. Let's make it a little bigger. So I don't mind that the plate is a little attenuated as it approaches the toe. It's not going to be flush against there because remember there's a little cartilage here. But the course is straight. It makes a clean arc all the way from one side to the other. Now in this case, in the second toe, we tape the toe back a little bit. Let's see what happened to the second toe. Really not much of a secret, is it? Here's the second toe. Where's the plate? That's a piece of plate. That's about all you got. So when we tape the toe back, the metatarsal flopped right out of there. You may say, well, that's pretty easy. Yeah, it is. But I wanted to show you a gross one with some normal plates. And I'm going to show you another one that's kind of more intermediate in a few moments. The dorsal capsule's ruptured. Now, who gets these? High heel wearing women with long second metatarsal heads. Caveat. Patient has toe pain, rule out Freiberg's infraction. Rule out stress fracture. You do an MRI. The MR is negative. The answer is you missed a second plantar plate fracture if there's fluid in the second MTP. Go back and do it again. So an effusion in the second without another explanation in a woman who wears heels is a plantar plate tear until you disprove it. That will save you. Actually, can we go back to that one? I apologize. There were several other findings I should have shown. A little too overeager. My apology. By the way, there's your third plate right there. And there's your displaced, subluxed second plate. So you can actually see the plate injury in the short axis. And I failed to show you the collateral ligament injury. Let's see if we have a long axis. I think we do. So there is no radial collateral ligament. There's a high-grade tear of the medial collateral ligament. So a very complex, unstable case. About the extensor tendon. Well, that's still there. There it is. Okay, now let's do another one. Apologize for that. Professional athlete, pain in the big toe. Let's go sagittal. This is midfield, open, 0.7T. Pictures could be a little crispier, but they get the job done. T1. A second T1. Let's put in our fat suppression PD and our T2. This is slightly complicated. This man makes about $1.5 million every Sunday. So if you say he's not playing on Sunday, $1.5 million. No pressure. All right, let's scroll. Medial sesamoid, not fractured. Let's go through our checklist. Lateral sesamoid, not fractured. While we're here, fibular head of the flexor hallucis brevis, intact. Let's go back to the medial side. Flexor head of the flexor hallucis brevis, medial side, swollen but present. Flexor pollicis longus, flexor hallucis longus, intact. Articular surface, normal for a performance athlete. Plate, defect. Now, we have to decide, is the defect more than 50% across or not? Looks pretty good over here eccentrically on the medial side. It's present on one 3mm cut. Starting to go away, it's gone. So it's on 2 of 6 or 7 sagittal slices. It's less than 50%. So what did we do? Sat him down for 2 weeks, no operation, and then he played again for the rest of the year. So the MRI was used to manage this patient non-surgically. All right, let's look at the short axis view. See the shape of his crista. Normal crista apex, normal smooth hyaline cartilage, normal conformity relationship, fibular sesamoid to toe. Medial side, not so much. Do you all appreciate the asymmetric shape of this compared to that? That's part of the checklist. That's why this sesamoid is sclerotic due to repetitive impaction and altered mechanics of weight bearing. Collaterals, part of our checklist. Didn't check those yet. Let's have a check. Remember Our Lady with the long second toe and the awful collaterals? These are normal collaterals. Now, I did say earlier that his flexor hallucis brevis attachment to the tibial sesamoid was intact. That's true, but it isn't normal. See how swollen it is right there? Right there. That is different than that. So he's got a strain of the FHB medial head. It's a complex case. It's no coincidence that he's got a strain of the FHB medial head on the side where we have the remodeled sclerotic sesamoid and the remodeled dysplastic crista groove. This is turf toe. Non-surgical turf toe. possible apophysitis, growth plate injury, potential injury to the lateral ankle or peroneal tendons. In March, someone stepped on her ankle. She had a fracture. Was re-injured in August after stepping into a hole. The pain, which was lateral, has propagated into the heel, and she has what she describes as swelling and a stiff feeling. Let's go to the sagittal. Got 3 of them. T1, PD, gradient echo. So the pain goes into the heel. She does not have apophysitis, which would be one concern in a juvenile. They were concerned about her peroneus brevis. She does not have a peroneus brevis tear. Very few 19-year-old girls do. They were concerned about a growth plate injury. If you have a growth plate injury, admittedly, it can be challenging to decide how thick is too thick. The metaphyseal side of the growth plate is always going to be a little shinier than the other side, because this is the side where the cartilage cells stack up to make the bone grow. So this is where the proliferative zone is. That's normal. What can you use as a concrete, quick, expedient, indirect sign of a real growth plate problem? The periosteum. Nobody has a growth plate injury without a little periosteal bleeding. She does not. That's normal cartilage. There's no bleeding going up underneath this black line in front or in back. That is a virtually 100% reliable sign for a Salter-Harris 1 or greater fracture. So we haven't answered the question. Or have we? And when you look at the foot of, say, a 15-year-old boy or girl playing American soccer, so-called European football, you'll see a lot of little dots in the bone. These dots are most conspicuous. They're random. They're hyper-intense. They show up on the PD spur. And you are seeing accelerated bone turnover with transient osteoclastosis and hyperemia. This is a known physiologic event of what we call the lower extremity juvenile foot abuser. Sometimes they have pain, sometimes not. The treatment is to try and slow them down a little bit. It's not worrisome. But should you have edema that is peripherally based, patchy but subcortical, in almost every bone, you've got complex regional pain syndrome type 1. Type 2 is when you have a nerve injury. And this is a critical diagnosis to make. For the longer it goes, the harder it is to correct. The longer it goes, the greater the risk is to the extremity long term. What is the treatment for this condition? Movement. So the last thing you want to do is have the surgeon say, oh, overuse syndrome, put him in a boot. That is exactly the wrong treatment, and you'll make them worse. You want them to move, to walk. And if physical therapy and movement doesn't work, then the next treatment is lumbosacral plexus block, and they get better right away. Sometimes it takes 2 or 3 blocks. In children, complex regional pain syndrome is more likely to cause the loss of an extremity than it is in an adult. So it's an even more serious condition to overlook in a child. The key, subcortical edema. in the absence of a synovitis or a capsulitis. For certainly in a capsulitis or a synovitis, you could get reactive subcortical swelling. This patient has no capsulitis, no synovitis, no JIA, which is the only other differential diagnostic consideration, although transient. You can toss it out. This is complex regional pain syndrome, type 1, previously known as the artist Prince. No, previously known as RSD. Another caveat before we quit. Some of you might have noticed this, an extra structure down low. That is a muscle bundle known as a perineal calcaneal muscle or peroneus crucius. This one attaches to the perineal calcaneal tubercle. The history in this 55-year-old is medial pain, pain with walking, sensation of instability. Pain is 2 to 3 months. She had breast carcinoma in 2013, a hysterectomy for unclear reasons in 2014. Let's go sagittal, be consistent. This was obtained on a Hitachi oval, 1.5T, T2 spin echo with fat suppression on the right. A good cleanup, clarifying sequence for tendons and ligaments. On the left, an adage, a detection sequence for tendons and ligaments, but like all gradient echoes, deficient in the medullary space, deficient in the assessment of enchondral or spongy bone. Yeah, it does show the cysts, I admit. In the middle, the T1. Within the subtalar space is abundant inflammatory gray tissue, synovial hypertrophy. What lives inside this space? The talocalcaneal interosseous ligament. There it is. The dominant cervical ligament. There it is. And more laterally, the extensor retinaculum, the part underneath the sinus tarsi, is known as the frondiform or stem ligament. There it is. What else can we glean from the sagittal? Lots of things. There's a posterior capsular effusion. There are some varices in the plantar space. There's evidence of midfoot arthrosis. There's evidence of swelling diffusely throughout the sinus tarsi. The lateral tendon group is normal. There's the peroneus brevis. Here comes the peroneus longus. One not quite as healthy, but present. It's a little tendinopathic as it makes its arcuate segment. These structures are prone to injury behind the fibula. And then the brevis is prone to injury at the cuboid tunnel, at the os perineum, and less commonly at its insertion on the base of the first and medial cuneiform. How about the medial tendon group? Well, as we're whizzing by, there's the Achilles. It's gray, it's irregular, it's wavy. That's magic angle effect. On the T2, it dissipates. The anisotropic 55-degree artifact of having collagen 55 degrees oriented to the main magnetic field. Linear, present on short TE, gone on long TE. Normal. So we're whizzing by our Achilles, headed for home. More erosions, more arthropathy. Let's check out the medial side. Flexor hallucis, it's intact. Now, the hallucis is a little bit like the flexor of the shoulder, the biceps flexor. The biceps sheath communicates with the shoulder joint. So when you have fluid, if it's going to decompress, it'll decompress into the biceps. Sometimes it becomes symptomatic, as in adhesive capsulitis. In the foot, if you have fluid in the joint, it'll decompress into the flexor space around the flexor hallucis longus. The flexor hallucis longus may crisscross with the flexor digitorum down low. Here they are crisscrossing, and the fluid just sits there around these two structures. This is called Henry's master knot recess. When there's a lot of fluid there, surgeons are tempted to remove the cystic mass. Don't let them do it. All right, let's go back to our sagittal. We're not done yet. We're getting in the habit of becoming sagittal friendly. How about our flexor digitorum? It's fine. How about our navicular? It's fine. But what's going on next to the navicular? What lives there? Spring ligament. What also lives there? Posterior tibial tendon. Distally, a bit irregular and frayed. Proximally, kind of gray, ill-defined, wispy. Look at its signal on the adage image. Severely diseased, diffuse peritendinitis. There's also a little spur we didn't see at first glance, did we? Coming off the navicular. Now it's time to apply our axial and look at our plantar flexion. Perfect. It's so beautiful, I want to cry. It is perpendicular to the tendon. Let's put up a T1 and an adage short axis view. Now, it is very uncommon to have disease that is primarily centered at the insertion of the posterior tibial tendon. This patient has disease there, admittedly. That's not the only place. So this is a bit exceptional, a bit unusual. There's edema in the navicular. So we call this a tendinous, bony penetration, rim rent type tear, exaggerated by remodeling and spurring of the navicular. Now let's move on up. Down low, this tendon is a registrar's dream because it inserts on everything. All you have to remember is the navicular and every other bone. So if they give you some other multiple choices, say yes. But now let's work our way backwards. Focality. Don't like it. I think it's time to put up the T2 and see what happens in a chronic situation. And this is chronic. Linearity, linearity, hard to see. Because that linearity is filled with scar and hemosiderin and fibrosis. Let's keep going, shall we? The T1 is even better than the adage, which is better than the T2. Again, chronicity. That is the mother, the goat of all spring ligaments. Look how thick that is, because it's carrying the load for the deficient posterior tibial tendon. Let's keep working our way up. Now it has split into multiple fragments. So it's a big longitudinal split tear. Remember what a split is? Split through and through. Half the tendon, delamination. In the tendon, intrasubstance delamination. Terminologies you need to learn. Keep going. Keep going up. Still split. Harder to see on T2, but still split. Still diseased, but not split. And what's this? A torn medial retinaculum. What is that? That's another piece of the tendon. So here's what happened. The back part of the tendon is sliced in half, and the back part has torn off and moved up proximally. This part has a complex reed of interstitial tear inside it. So you were actually only seeing the anterior half of the tendon. The posterior half of the tendon was off the screen. That's crazy. There it is. That's Tom, that's Dick, that's Harry. You don't get two Toms. You only get one Tom. So where is the posterior tibial tendon at risk? Usually it starts right at the bottom of the medial malleolus, unless you've got an anomaly or deformity, like a little spur or bifid groove. So there's a spur in the front, spur in the back, that deepens the space and increases the friction of coefficient of the tendon as it glides. The tear starts there and then propagates distally. So this is a tear that involves the supramalleolar, juxtamalleolar, inframalleolar, and insertional portion of the PT. The posterior segment of the tear is torn and retracted 3 centimeters above the malleolus. The tear is hypertrophic, complex, and associated with navicular deformity and remodeling and a massively thickened spring ligament. That's how you would record the conclusion. You could add or put in the body of the report that the medial retinaculum is also torn. And then I probably, in this case, because it's so prominent, would include in the conclusion the sinus tarsi synovial reaction. PT tear. Let's go sagittal. Stay with the same theme. Achilles tendonitis. The patient has difficulty pressing on her heel and now has developed, due to altered mechanics of weight bearing, pain in the heel and the foot. Rule out plantar fasciitis. Well, it'd be pretty hard to rule out plantar fasciitis here, wouldn't it? It's all the way in the back over there in Brisbane. We're over here in Perth. Not going to work. All right, so let's focus on the other part of the history. Pain in the foot. That's helpful, isn't it? So let's start out with the first MTP. Hypertrophic deformed fibular sesamoid. Arthritic, flattened, thinned, edematous, tibial sesamoid with sesamometatarsal chondromalacia. Remember, there is hyaline cartilage here. So that's arthritic. It's going to hurt. It's a man, by the way. Presumably he's not a high heel wearer. So far, I'm underwhelmed by the marrow signal other than that which we've identified near the sesamoid. All right, let's get desperate. We'll go to another projection. The short axis view. I'm going to blow them up. T1 on the left, T2 in the middle, and PD fat suppression on the right. Go ahead and scroll in the short axis projection. Diagnosis: Morton's neuroma. What is a Morton's neuroma? It is a fibroinflammatory reaction around the digital nerve that is locked or sandwiched between the ligamentum, metatarsum, transversum profundum, and superficiale. So there's a superficial ligament, there's a deep ligament. Can you see them? You could if you had a microscopy coil. Typically, the toes rub together. What makes them rub together? If they've got deformity, or are they like shoes with a tight point and a heel, which pushes the toes together? So this is a friction-induced intermetatarsal entrapment neuropathy. It usually affects the common digital nerve, which are branches of the plantar nerve. Now, when do you actually say Morton's neuroma, remembering that it is not a true neuroma? It's not a neurolymoma, it's not a schwannoma, it's not a neurofibroma, it's scar tissue with a disorganized nerve. When it makes a shape of 6 millimeters or greater, and it's round, or it makes a shape of 6 millimeters or greater, and it looks like a peanut, like this one, then you can call it a Morton's neuroma. What's the most common location? 2, 3, 3, 4. When do you operate on them? Almost never, because it's scar tissue. And what happens when you operate on scar tissue? You get scar tissue. So if you are a young lady out there and you like wearing your heels with a narrow toe, stay out of the narrow toe for a while, get some little spreaders for your toes. It's okay to take a little steroid injection. That's as far as I recommend you go. Now, if they're very large and associated with deformity of the toe, then they will actually excise the digital nerve and realign the toe. But that is about 1 out of 100 cases. They also will remove these if they're large without deformity arthroscopically. How large is large? Large enough so that conservative management has failed, they're over 1 centimeter in size, and you've tried all the usual maneuvers. Morton's neuroma. Perineural fibrosis, therefore, signal intensity on T2, dark, but not black. T1, gray. Water-weighted image, still dark. Shall we look at another? Let's go up with the sagittals. This was done on a Hitachi Oval, 1.5T. On the left, PD, actually T2 fat suppression. In the middle, additive gradient echo. On the right, T1. Let's play. Where's all the swelling? Medially. Is there any swelling laterally? Not much. At least not under the fibula. But what about here anteriorly? Massive swelling. The most. Let's keep looking, shall we? He's got a large os trigonum, or old shepherd's fracture. Bless you. He has a little subtle swollen area along the posterior malleolus with periosteal elevation, just as you might see had he been a juvenile with a low-grade Salter-Harris 1 injury. But he's not a juvenile. He's a young adult man, a big man. His growth plates are closed. It is not uncommon to see a scar at the closed growth plate for years or forever. Let's keep looking, shall we? We're getting sagittal, sophisticated. Peroneus brevis and longus. Brevis, good. Longus goes into the cubital tunnel. Good. Goes over to the medial side of the foot. We can track it. Compartment 2, there are 2. Compartment 1, there is 1. Compartment 3, Tom, Dick, and Harry. There's Tom. Lots of swelling in front of Tom. There are fibers of the deltoid. Where's Dick? Here's Dick. And there's Harry right there. That's Harry. I picked it up a little asymmetrically there. It's kind of volume averaged with the PT. The anterior group, let's make it a little smaller. Most important one, the tibialis anterior, which inserts on the medial cuneiform in the base of the first for you test takers. That looks fine. Talar dome, fine. Macrofracture, no. Microtrabecular fracture, yes. Have you seen it? Right there. All right, so the middle facet has a bone injury. The posterior facet has a bone injury. We're not done yet scrolling sagittally. This time they did give us the plantar fascia. It's not part of the case. It's normal. What about the subtalar space? Oft overlooked and ignored. Medially, there is a round object that's about 5 millimeters in diameter called the talocalcaneal interosseous ligament. I see a vestige of it right there. As we move laterally, I should see a nice, straight, celery stalk cervical ligament. That isn't nice, straight, celery stalk-like, is it? Most laterally, I should see a nice, straight, parallel, frondiform ligament. I don't. Is there a question? So I am struggling to identify all 3 components of the subtalar space. Now, this is a completely unexpected development in this patient. Let's go to an axial. Put it right in the middle. We've got 3 tendons, 2 tendons, 1 tendon in the back, and 4 tendons in the front with a massive hematoma anterolaterally. We said there was no macrofracture. Maybe that's an incorrect statement. Maybe a tiny depressed macrofracture right there. If you called it a microtrabecular fracture, I think that would be more appropriate, just because of how small it is. Is there a tiny cortical chip there? Perhaps. We didn't CT him. We're not done yet. We've established that at least the tendons are okay, but what about the anterior talofibular ligament? There's a piece of it. There's another piece of it. Do they connect? Absolutely not. There is no connection. The ATAF is ruptured. What about the calcaneofibular ligament? It's pretty wavy, going in the wrong direction. It's also ruptured. Checklist, checklist. How about the talar dome? Okay. How about the peroneus longus and brevis? Established. Okay. How about the retinaculum holding them in place? Tight, dark. Okay. How about the high ankle? Let's check it out. Let's pull up our coronal and see if there's any swelling in the interosseous space. Not really. Just a tiny bit down low. Here is the interosseous ligament, right there. Very slightly swollen. No diastasis. Pretty dark. No defect. High ankle, spared. Almost done. Subtalar space, sinus tarsi. Let's mag out. By the way, it's an inversion injury. Here's his calcaneofibular ligament. And let's just check out his deltoid for giggles. It's a little swollen. Some of the fibers have come detached. We don't care. That's a common secondary minor injury. It'll get better. What about our talocalcaneal interosseous ligament, which sits right here? Torn. What about our straight celery stalk cervical ligament that sits right here? Torn. What about our frondiform ligament, also known as the stem ligament, the deep portion of the extensor retinaculum? It looks like a kangaroo. Can you see it? There's the eye, there's an ear, there's the nose. It's a kangaroo. Sometimes you will spy a cyst coming out of this space. There's a bursa that lives here, and this is known as the stem ligament bursa. It presents as a cystic mass superolaterally in people with subtalar disease. It's not a ganglion, it is a bursal cyst that can be treated with aspiration. Usually ganglia have to be resected. So the patient has torn all three components of the subtalar space, medial, intermediate, and lateral, has a two-part ankle rupture without tendinous injury, without osteochondral injury of the talar dome, with several microtrabecular injuries, period. The last time I was here, there was a lot of interest and requests regarding infection, so I came prepared this time. So we're going to have the knockout round right now. You get a case, you scroll it, and you come back to me and say, osteo, septic arthritis, none of the above. If you see air or gas, call it out. Now, you don't have to call out to the audience if you don't want to. You can simply reflect and make a decision. But I want you to make a decision. It shouldn't take you very long. Evaluate for osteomyelitis of the fifth toe plantar. Patient had a cellulitis. For the age of antibiotics, a cellulitis could be fatal. Calvin Coolidge, one of our earlier presidents, his son was playing lawn tennis. He got a cellulitis from sliding on the lawn. He died 2 weeks later from streptococcal septicemia. Today we don't have that problem to face. But we do have a cellulitis in this case. We've got a short axis T1, a short axis water-weighted image. I think contrast was given. Contrast shows diffuse enhancement of the soft tissues. Did we need it? Of course we didn't need it. Osteo or no osteo? Let's go to the long axis view. Sagittal T1, we said, was the ultimate, the penultimate sequence. Osteo, no osteo? No osteo. Done. Didn't need the contrast. Didn't need the water-weighted image. T1 solves it. Next. You're 1 for 1. Ankle, foot, chronic, neuropathic ulcer in a diabetic with erosions. Evaluate for osteo. Wound is at the great toe. Stay with the sagittal. Now, admittedly, there's a little motion here. One of the challenges of the sagittal is you could get off to the side eccentrically and B, volume averaging the soft tissues. So you may not be sure whether you're in the bone or out of the bone. So perhaps it's a good idea to get something that's orthogonal. Yeah, I'm going to give you all the diabetic amyotrophy, fatty replacement of the muscle. I'm going to give you the arthritis. I'm going to give you the destroyed crista and crista sulcus, the irregular sesamoids. What about osteo? Yes, we do have it. Right there. Your colleagues astutely picked up on it. Bone erasure, right at the tip. Look how easy that is. Sagittal T1, ax T1. Ax T2, useless. Let's look at the coronal. There it is right there. Tip of the toe, eaten away. Next. You're 2 for 2.
315, 315.
It's not hard at all. Look how much money we're saving the Australian government in not injecting people with indium. Look at what we're doing for the environment. And it also is a quicker study. Let's get in front of the government and make the case. I'm in. 82-year-old man with non-pressure ulcer, lateral 5th digit. Swollen foot, sagittal. Let's go to the pinky toe. This one's a little tougher. A little bit harder. Now, if I see some high signal on the water-weighted image, and I don't see bone erasure, but the cortex and periosteum are swollen, I'll call that cortical osteitis. A synonym used in some parts of the world is non-penetrating, non-invasive osteo. Those are treated as an outpatient, often with oral medication. If it's in the medullary bone, PICC line, IV therapy. So we're out on the edge. Now, we said the T2 weighted image, not very useful. It's insensitive. But if it's positive, if the converse is true, that's really helpful, because that means there's a tremendous amount of swelling and water in the bone. So the odds of having an abnormal T2 with a normal T1 are virtually 0. So T2 lacks sensitivity, but it has specificity. So there is some swelling on this T2 stir. Let's go to our T1. It's a little tougher than the other cases. This one's tricky, but the answer's there. Osteo or no osteo? Yes, right there. Where'd the cortex go? Where did the cortex go? 3 for 3. Sorry? Is there septic arthritis? There absolutely is. Septic arthritis and osteomyelitis. No air, no gas. It is in the joint. There's very subtle involvement of the base of the proximal phalanx. You are correct.
250, 250.
78-year-old with chronic ulcer of the midfoot. Got a plantar ulcer at the level of the second MTP. Let's Go to the sagittal. Let's go to the second MTP. Wow. Okay, the plantar plate is ruptured. There's the ulcer. He's got an ulcer because the bone is subluxed, pressing against the ground. So that's what caused the ulcer. This time we have signal on both sides of the articulation. We have loss of bone substance along the plantar aspect of the metatarsal, right there. Look at the bone erasure at the base of the proximal phalanx. Let's look at it in the short axis view. There's some bone loss right there. That's real. So big penetrating ulcer, osteomyelitis, septic arthritis. Let's go back to the sagittal T1. We got to cut this person's foot off, at least a toe. Where are we going to make the cut? Right there. Proximal to that spot. So the MR makes a diagnosis and tells us where we have to amputate. Next. And that one has septic arthritis too.
251. 251.
Heel ulcer for 3 weeks in a patient with spina bifida. So in the hind foot, the sagittal is less useful. Probably more useful would be to go to the short axis, but we'll be consistent. There's a massive confluent ulcer. What's in the ulcer? Proteinaceous fluid. So if you perform a diffusion image on this, it'll diffusion restrict. It's an abscess. If you did spectroscopy, it would show a glutamate peak, would show a lactate peak. You don't need that. Now we got to decide if it's in the bone. Let's go to the short axis. You have to make a decision, yay or nay. Yay. The eyes have it, and there it is. How easy is that? Erased bone. That's osteomyelitis. That's cortical and subcortical osteomyelitis. Look how much money we are saving the Australian government. Let's keep going.
For the gold. 253.
For the gold.
253.
Fracture of the fourth toe in a diabetic. Diffuse swollen of the fourth MTP. Basic case. Let's go to the fourth. We only have 2 sets of images in the whole case. Why? Because that's all we need. What do we got? Septic arthritis. Both sides of the articulation. Let's blow it up. Bone erasure. Bone edema. Look carefully. More bone erasure. Septic arthritis with osteomyelitis. Pretty easy. Okay.